In this video, we will demonstrate our technique using an infratuberosity anterior closing wedge high tibial osteotomy for slope correction in ACL deficient knees. These are our disclosures. We begin with preoperative planning. The three key components are measuring the posterior tibial slope, assessing the start point of our osteotomy cut, and determining the osteotomy size. The surgical planning was performed with the lateral full-length tibial radiograph using the PeakMed software. Briefly, a first line is drawn parallel to the tibial plateau, and a second line is drawn from the most anterior part of the tibial plateau through the center of the tibial metaphysis and diaphysis. The angle formed between these two lines is then subtracted from 90 degrees and defined as the posterior tibial slope, as demonstrated in Figure A. The anticipated correction angle and width of osteotomy wedge was calculated, as seen in Figure B. We always start 3 centimeters below the patella tendon insertion, with our hinge positioned about 5 millimeters anterior to the PCL insertion site. In this patient, a 10-degree correction corresponded to a 12 millimeter cut. The targeted posterior tibial slope after surgical correction is recommended to be between 5 to 8 degrees, as prior studies have raised concerns of overcorrection, leading to increased strain on the posterior cruciate ligament.
We then switch to the surgical procedures. Several steps have been done before the osteotomy, including graft harvesting and preparation, arthroscopic exploration, meniscus and cartilage repair, femoral tunnel for the ACL, and the lateral tenodesis. The approach is slightly medial, extending the classic hamstring harvesting approach. We then elevate the MCL and protecting it with the hormone retractor. We do the same with the anterior tibialis muscle, incising first the periosteum and the aponeurosis of the muscle to put a hormone retractor and be able to protect it from the beginning to the end. We mark the distal aspect of the tibial tuberosity 3 cm below the insertion of the tibial tubercle. The X-ray on the lateral view need to be perfect before putting the X-ray with the complete superimposition of the two condyles. We then shoot 2 ascending X-rays positioned distally onto the tibial tubercle that will help us to drive the saw blade ascending from this anterior point to the insertion of the PCL, that is the hinge point for the rotation of the osteotomy. We resect this fragment. It can be measured to confirm that its length is around 11 to 12 millimeters. We have this aspect then. The osteotomy is then closed by cutting the remaining part of the triangle on the lateral and medial side. The plate is positioned anteriorly once we feel that the osteotomy is moving to be and the knee being in flexion. The position of the plate need to be perfect. We confirm that on X-rays. Then shoot the two proximal screws to be able to close the osteotomy down with the compressive screws. We verify the position of those 2 screws compared to the joint line, then extend the leg and compress the osteotomy by recurvatum measures. We use a compressive screw to compress the osteotomy site onto the bone and finish the locking of the osteotomy using free locking screws. We always verify the position of the plate. The next step will be the tibial tunnel, ACL graft fixation that need to be doubled at the tibia, fixation of the lateral tenodesis, and finally skin closures. This is the final X-ray of this patient in frontal and sagittal view with the complete closure of the osteotomy gap. Post-op rehab include 3 weeks of non-weight bearing, and thank you for watching.